When you look at an X-ray of a fractured radius, and there it is, a jagged white line, it's binary, broken or not broken. We really crave that kind of macroscopic certainty in medicine.
Oh, absolutely. We want a clear yes or no.
Right. But when you step into the realm of systemic human pathology, suddenly the X-ray machine is just, well, it's useless. We are looking at this diagnostic landscape for you that is incredibly murky, where the definitive answers hide inside individual cells.
Yeah, and that murkiness is exactly why pathology is so complex. I mean, the macroscopic clinical signs we see at the bedside, they're always just downstream echoes of a microscopic cellular war.
Okay, let's unpack this. Think of this deep dive into the USMLE Roadmap Pathology, edited by Dr. George R. Wedach, as a guided tour of a microscopic crime scene.
I love that analogy. It really is a crime scene.
It is. And our mission today is to translate these dense scientific facts into an engaging, logical journey through the human body and disease. We want to explore not just what happens, but, the molecular mechanisms of why it happens.
Right. And before we can even examine specific organ failures, we have to establish the baseline of cellular injury. Like when a forensic pathologist is at the autopsy table, they're looking at 5 official manners of death.
Which are natural, accident, homicide, suicide, and undetermined, right?
Exactly. And those macroscopic findings translate directly into a cellular story of toxicity.
So when forensic pathologists examine a body, they aren't just playing detective for the law, right? How do these macroscopic clues tell a cellular story of toxicity? Like with acetaminophen.
Good example. Take a massive acetaminophen overdose. The macroscopic finding is a distinct nutmeg pattern on the liver.
Nutmeg, like the spice.
Literally looks like a grated nutmeg seed. And if we look at why that happens, it's because the toxic metabolite, NAPQI, it overwhelms the liver's glutathione stores.
Oh, wow.
Yeah, and that leads specifically to central lobular necrosis. The cells immediately surrounding the central vein of the hepatic lobule, they die first.
Because they have the highest concentration of those CYP450 enzymes, right? The ones that actually generate the toxic metabolite.
You nailed it. The result is these congested necrotic red centers surrounded by pale, surviving periportal tissue, hence the nutmeg look.
Man, I've always found cyanide poisoning fascinating from that mechanistic standpoint, too.
Oh, cyanide is a classic.
Right. The macroscopic clue is a bitter almond odor during autopsy, along with hemorrhagic gastritis. But at the cellular level, the toxin is basically suffocating the cell.
Yeah, by binding to cytochrome Hets oxidase in the electron transport chain. The cells can't utilize oxygen, halting ATP production instantly.
Just a total systemic metabolic block.
Exactly. And physical trauma leaves just as striking a histologic record. I mean, with electrocution, a massive current like lightning leaves the Lichtenberg sign.
That's the arborescent fern-like burn pattern on the svan, right?
Yes, it looks like a branching tree. Microscopically, the intense heat actually flash boils tissue water. It causes vacuolization of the epidermis. You can literally see the nuclei of the cells streaming or elongating in the direction of the electrical current.
That is wild. So physical or chemical trauma pushes the cell to a breaking point. But cells don't just instantly die, do they?
No. They try to adapt first. They use reversible injuries like hyperplasia, hypertrophy, atrophy, or metaplasia. They alter their steady state to handle the strain.
Right. They try to survive.
But once the stress exceeds the cell's adaptive capacity, say there's massive membrane damage or mitochondrial ruin, we cross the threshold into irreversible injury. And what's fascinating here is the stark mechanistic difference between how a cell dies when it's murdered versus when it commits suicide.
Meaning necrosis versus apoptosis.
Exactly. Necrosis is a messy pathologic process. ATP depletion causes ion pumps to fail. The cell swells, the membrane ruptures, and it basically vomits its intracellular enzymes into the surrounding tissue.
Which incites a massive inflammatory cascade. Just a total mess.
Exactly. Whereas apoptosis is an organized suicide. The cell activates caspases. It shrinks.
No inflammation at all, right?
Right. The chromatin condenses and fragments neatly, and the cell breaks into apoptotic bodies that macrophages quietly consume. It is a highly conserved, clean disposal.
So we have these dead or mutated cells, and identifying them under light microscopy is standard, but nowadays we need to know their exact molecular signature.
We really do. We're moving from the autopsy table to the molecular lab.
I was trying to conceptualize immunohistochemistry, or IHC, and it struck me. Using IHC is essentially like handing out specific neon-colored hats to suspects in a crowd so you can spot exactly who is who.
That perfectly captures the mechanism. We use antibodies linked to an enzyme or fluorophore that targets specific cellular antigens.
So if we have an undifferentiated tumor in a lymph node,
We apply an antibody for cytokeratin. If it binds and stains, we know the cell has epithelial origins, meaning it's a carcinoma.
okay, that makes sense.
If it stains for CD45, the leukocyte common antigen, we're looking at a lymphoma. PSA flags prostate origins, and alpha-fetoprotein, or AFP, points toward yolk sac tumors or hepatocellular carcinoma.
So IHC identifies the proteins the cell is actively producing. But Fischer's fluorescent in situ hybridization, that goes straight to the genomic blueprints, right?
Yeah, Fischer's targets the DNA itself. We use fluorescently labeled DNA probes that hybridize to complementary target sequences on the chromosomes. It's heavily utilized in breast cancer.
To detect the amplification of the HER2/neu gene.
Exactly. If a tumor cell has massive amounts of HER2/neu copies, the nucleus lights up with dozens of fluorescent dots rather than the normal 2, and that dictates the use of targeted therapies.
That's an acquired mutation, but we also use molecular tools for inherited genetics, right? Like Huntington disease.
Yes, Huntington relies on finding an autosomal dominant trinucleotide expansion. The CAG repeats within the HTT gene.
And for that, we use PCR to amplify the DNA segment and measure the exact number of repeats.
Right. And PCR is equally crucial for infectious diseases. Take cytomegalovirus, CMV. Traditionally, a pathologist would look for the classic owl-eye intranuclear inclusions.
Under the microscope.
Yeah. But PCR allows us to quantitatively measure the viral DNA load in the blood of an immunosuppressed patient, long before those morphologic owl-eye inclusions ever form in the tissues.
That's incredible early detection. Okay, so armed with these diagnostic tools, let's start applying this clinically for you, beginning at the body's primary barrier, the skin and upper airways.
The dermatology and head and neck section.
Yeah, and here's where it gets really interesting, because visually, pigmented lesions can look remarkably similar. We hear about skin lesions all the time, but pathologically, how do you differentiate a harmless aging spot from a deadly cancer?
Well, the architectural pattern is everything. Take a seborrheic keratosis. Clinically, it's a greasy, stuck-on lesion.
The ones that look like you could just peel them off.
Exactly. Under the microscope, it's a benign proliferation of immature keratinocytes. The hallmark is the presence of keratin-filled horn cysts. Crucially, it respects the boundaries of the epidermis.
But a melanoma breaks all those rules.
Completely. It demonstrates cellular atypia and lacks maturation as the cells descend into the dermis. But more importantly, you see pagetoid spread.
What's that?
It's where malignant melanocytes ascend singularly or in nests into the upper layers of the epidermis. Normal melanocytes simply do not do that.
Now, with basal cell carcinoma, BCC, the text mentions two very specific microscopic features, peripheral palisading and a clefting artifact. I've always wondered why that clefting happens. Is it an inherent structural part of the tumor?
It's actually an artifact of tissue processing, but it's highly diagnostic. BCC tumors secrete large amounts of mucin.
Okay.
When the tissue is dehydrated during slide preparation, that mucin shrinks. This causes the tumor nest to physically pull away from the surrounding fibrous stroma, creating a visible empty cleft.
Oh, so the slide prep itself creates the clue.
Yeah. And the peripheral palisading, which is the outermost layer of tumor cells lining up in a neat parallel row, that's a reflection of the tumor's basal cell origin, trying to mimic the basal layer of normal epidermis.
It's fascinating how processing artifacts become diagnostic criteria. The immune system also paints some vivid pictures on the skin.
It definitely does.
Like the hyperkeratosis and parakeratosis in psoriasis create those silvery scales, right? The parakeratosis specifically means the cells in the stratum corneum are proliferating so fast they don't have time to extrude their nuclei.
Exactly. Contrast that with discoid lupus erythematosus. You see interface dermatitis, where inflammatory cells attack the basal layer of the epidermis.
There's heavy follicular plugging.
Right, where that excess keratin actively dives deep into the hair follicles, clinically causing scarring alopecia.
Let's transition deeper into the head and neck. When the immune system stops attacking the epidermal junction and targets the blood vessels themselves, we see vasculitides like Wegener granulomatosis.
This is a severe necrotizing granulomatous inflammation heavily associated with CA-NCA autoantibodies.
And microscopically.
The defining feature is neutrophils actively invading the walls of small to medium arteries, causing fibrinoid necrosis of the vessel wall. It classically destroys the upper airways, lungs, and kidneys.
Wow. And just adjacent in the neck, the salivary glands offer their own distinct histology, particularly the pleomorphic adenoma in the parotid gland. The name pleomorphic suggests it's a mixed bag of cells, right?
It is a biphasic tumor. It arises from both epithelial and myoepithelial cells, which somehow possess the ability to produce a vast array of stromal matrices.
Like what kind of matrices?
Under the microscope, you see ducts of epithelial cells floating in the background that looks myxoid or even like mature cartilage.
That's so weird.
It is.
So that structural breakdown we discussed in Wegener's, where the arterial walls are destroyed, that provides a perfect conceptual bridge to the cardiovascular system. We're moving to the engine room.
The heart and lungs.
Yeah. We spend a lot of time focusing on atherosclerosis as a luminal blockage, starving the myocardium and ischemic heart disease. But that lipid-driven inflammation also structurally degrades the tunica media of the vessel.
It really does. The arterial wall becomes drastically weakened. This is the primary driver of abdominal aortic aneurysms. The atherosclerotic plaque impairs the diffusion of nutrients from the lumen into the vessel wall.
Which leads to ischemic degeneration of the media.
Exactly. The wall simply balloons out under systemic pressure.
But if we look at the thoracic aorta, the mechanism of aneurysm formation is entirely different.
Completely different.
It's less about atherosclerosis and more about intrinsic matrix defects, like cystic medial degeneration seen in Marfan syndrome.
Right. In Marfan syndrome, a mutation in the fibrillin-1 gene leads to defective elastin fragmentation. The smooth muscle cells in the media undergo apoptosis, creating cyst-like spaces filled with amorphous proteoglycans.
And the thoracic aorta is constantly dealing with the massive shear stress of cardiac systole.
So without intact elastin, it dilates and frequently dissects. It's a mechanical failure.
That mechanical stress also batters the heart valves. In infective endocarditis, bacteria directly colonize the valve, creating bulky, friable vegetations of fibrin in organisms that just destroy the valve tissue.
But vegetation doesn't always equal infection.
Really?
Yeah, in systemic lupus erythematosus, we see Libman-Sachs endocarditis. Circulating immune complexes deposit on the valves, triggering inflammation and the formation of sterile vegetations.
Sterile vegetations, so no bacteria.
Right. And because it's a systemic immune process rather than a localized bacterial colony,
Right.
these vegetations uniquely form on both sides of the valve leaflet.
I see. It's almost like the anatomical location of a lesion, like an aneurysm or a lung tumor, is almost as diagnostic as the cellular makeup itself.
Oh, absolutely. Location is everything.
And the cardiovascular system and the lungs are a closed circuit. When left-sided heart valves fail, hydrostatic pressure backs up directly into the pulmonary circulation, leading to pulmonary edema. But when the alveolar capillary barrier is injured directly, say by sepsis or severe trauma, we see acute respiratory distress syndrome, or ARDS.
The mechanism here is profound inflammatory cytokine release. Neutrophils rush into the alveoli, releasing proteases and reactive oxygen species, which shreds the type ionocytes and the capillary endothelium.
So the barrier is just destroyed. Protein-rich exudate and cellular debris flood the alveolar spaces.
And as this fluid coagulates, it forms the classic microscopic hallmark of ARDS, which is hyaline membranes.
I've heard of those.
Yeah, these are thick, waxy barriers coating the alveolar walls that make gas exchange nearly impossible.
ARDS is an acute crisis, but the lungs are also the site of chronic insidious mutations. The anatomical location of primary pulmonary carcinomas is heavily tied to their cellular origin.
Definitely. Squamous cell carcinomas and small cell carcinomas generally arise centrally, near the major bronchi.
Why central?
Primarily because they originate from cells heavily exposed to inhaled carcinogens. Squamous cell carcinoma is identified by intercellular bridges and keratin pearls.
Whereas adenocarcinomas, which are the most common type in non-smokers, typically present as peripheral masses arising from the terminal bronchioles and alveoli, forming malignant mucin-producing glands.
Exactly.
That concept of toxic exposure dictating the pathology leads us perfectly into the gastrointestinal tract and liver. When we look at the GI tract and liver, it seems like inflammation is the root of all evil here. How does chronic inflammation permanently alter these organs?
Well, the pathogenesis of alcoholic liver disease is a prime example of that. The liver metabolizes ethanol into acetaldehyde, which is highly toxic. Initially, this alters lipid metabolism, causing reversible steatosis.
That's just fat accumulation in the hepatocytes, right?
Right. But as the toxicity continues, we see acute alcoholic hepatitis, and this is where those classic Mallory-Hyaline bodies appear.
Structurally, those are clumped, damaged intermediate filaments, specifically cytokeratin, within the hepatocyte cytoplasm.
Yes, they look like eosinophilic rope-like inclusions. If the insult continues, the repeated necrosis triggers hepatic stellate cells to secrete excessive collagen.
And that leads to micronodular cirrhosis.
Exactly, where the normal lobular architecture is entirely replaced by regenerating hepatocyte nodules trapped in thick, fibrotic scar tissue.
And cirrhosis isn't strictly toxic, it can be genetic too. Alpha-1 antitrypsin deficiency results in a misfolded protein in the endoplasmic reticulum of the hepatocyte that cannot be secreted.
And under the microscope, these aggregates form distinctive magenta globules with a PAS stain that resists digestion by the diastase enzyme.
Oh, that's a classic board clue.
It is. The physical engorgement of the ER causes hepatocyte apoptosis and eventual cirrhosis.
Further down the alimentary canal, idiopathic inflammation causes extensive structural remodeling in Crohn's disease, which is a transmural inflammatory bowel disease.
Right, because the inflammation penetrates through all layers of the bowel wall. It leads to fissures, fistulas, and strictures. Macroscopically, you see creeping fat.
Creeping fat? That sounds awful.
It's mesenteric adipose tissue that extends over the serosal surface of the inflamed bowel. Microscopically, the defining feature is the presence of non-case-eating granulomas.
Now, regarding filtration, the kidneys are the ultimate sieve. The glomerular filtration barrier relies on size and charge to keep proteins in the blood. So how does minimal change disease cause such massive proteinuria if the glomerulus looks completely normal under a light microscope?
It comes down to the nanostructure. The visceral epithelial cells of the glomerulus, the podocytes, have foot processes that interdigitate to form filtration slits.
Okay.
These processes are coated with a polyanionic lattice, a negative charge that repels negatively charged proteins like albumin. In minimal change disease, T-cell-derived cytokines damage the podocytes. Under electron microscopy, we see diffuse effacement or flattening of these foot processes.
So the structural integrity collapses, taking the negative charge barrier with it, and albumin just dumps into the urine.
Precisely, causing severe nephrotic syndrome. In contrast, focal segmental glomerulosclerosis, or FSGS, involves actual structural scarring, sclerosis in segments of some glomeruli.
And what about IgA nephropathy?
That is driven by abnormal glycosylation of IgA antibodies. These immune complexes get trapped specifically in the mesangium, the central stalk of the glomerulus, triggering proliferation and hematuria.
Processing fuel and filtering waste requires strict systemic regulation. So we're moving to the endocrine system and naturally to the reproductive systems it influences.
Right.
Diabetes mellitus is the textbook failure of this regulation. We have strict diagnostic criteria, a fasting plasma glucose greater than 126 or an HbA1c greater than 7%. But for type 1 diabetics, checking for ketones is a mandatory safeguard. Why does an absolute lack of insulin immediately trigger ketogenesis?
Because insulin doesn't just push glucose into cells, it actively inhibits lipolysis. Without insulin, the hormone-sensitive lipase in adipose tissue goes into overdrive,
Breaking down triglycerides into free fatty acids.
Exactly. The liver takes these fatty acids and undergoes massive beta oxidation, churning out ketone bodies like acetoacetate.
Which rapidly drops the blood pH, pushing the patient into life-threatening diabetic ketoacidosis.
It's a rapid cascade.
The endocrine system can also present with pathologies that clinically mimic totally different disease categories. Renal thyroiditis is a striking example of that.
Oh, renal thyroiditis is fascinating. It's a manifestation of IgG4-related systemic disease. It causes extensive, dense fibrosis of the thyroid gland. The gland becomes rock-hard, fixed, and woody on palpation.
Woody. So clinically, it strongly mimics an invasive anaplastic carcinoma.
It does.
Okay.
But microscopically, it's not a malignant proliferation at all. It's dense collagenous tissue with a heavy infiltrate of IgG4-positive plasma cells.
Wow.
If we connect this to the bigger picture, this is why histologic confirmation is non-negotiable before major interventions. We rely on targeted screening to catch cellular transitions early. For breast lesions, that means the triple test.
Which is the clinical exam, mammography for microcalcifications, and a tissue biopsy.
Right, to distinguish a benign fibroadenoma from an invasive ductal carcinoma.
The Pap smear is arguably the most successful screening tool ever invented for cervical cancer. It's looking for very specific cellular morphologic changes induced by high-risk HPV strains.
Yeah, HPV produces viral oncoproteins E6 and E7, which inhibit the tumor suppressor genes P53 and RB. This forces the cervical squamous cells into unchecked proliferation.
And on a Pap smear, pathologists look for coilocytes, right?
Yes, coilocytes are squamous cells with wrinkled hyperchromatic nuclei and a very distinct paranuclear halo. Catching dysplasia here prevents the progression to invasive carcinoma.
Moving into the uterus, the distinction between a benign fibroid, a leiomyoma, and its malignant counterpart, a leiomyosarcoma, highlights exactly what a pathologist looks for to define malignancy.
Leiomyomas are whorled masses of smooth muscle with uniform, bland, oval nuclei. Leiomyosarcomas, conversely, arise de novo.
They don't evolve from the benign fibroids.
Generally, no. The pathologist diagnoses malignancy based on 3 strict criteria: significant nuclear atypia, a high mitotic index indicating rapid cell division, and areas of coagulated tumor necrosis.
Because the mass is literally outgrowing its own blood supply.
Exactly.
So what does this all mean? We've traced pathology through the major organ systems, but we have to step back and look at the body's foundational structures and the congenital errors that dictate development from birth. A single point mutation can fundamentally alter the skeletal framework, as seen in chondroplasia.
And chondroplasia is driven by a gain-of-function mutation in the FGFR3 gene. Normally, FGFR3 inhibits cartilage proliferation.
So when it's constitutively active, it severely suppresses endochondral ossification at the growth plates.
Right. The long bones simply cannot elongate, making it the most common cause of dwarfism.
The skeleton is incredibly dynamic, which unfortunately leaves it susceptible to aggressive primary tumors. Osteosarcoma arises from primitive bone-forming mesenchymal cells. Radiographically, it creates a sunburst pattern.
Because the tumor breaks through the cortex, lifting the periosteum to form the Codman triangle.
And Ewing sarcoma is another highly aggressive pediatric bone tumor, classically composed of sheets of small, round blue cells. The diagnostic hallmark here is a specific genetic translocation, T1122, which fuses the EWS gene to the FLI1 gene.
That genetic precision is amazing. Let's look at the blood born within that marrow. A very common young adult pathology is infectious mononucleosis, driven by the Epstein-Barr virus infecting B cells.
But the characteristic cells we see on a peripheral blood smear aren't the infected B cells, right?
No, they are the activated CD8-positive T cells reacting to the virus. These atypical reactive lymphocytes are enlarged with abundant cytoplasm that actually scallops or wraps around the adjacent red blood cells.
And regarding red blood cells, transfusion medicine relies entirely on the ABO antigen system. Type O red blood cells lack both A and B antigens, meaning they won't trigger an immune response, making type O the universal donor.
Conversely, patients with type AB blood express both antigens, meaning their plasma does not contain anti-A or anti-B antibodies. They are the universal recipients for packed red blood cells.
To wrap up the pediatric side, the text covers storage diseases. These are profound examples of how missing a single lysosomal enzyme cascades into multi-organ failure.
They really are.
In Gaucher disease, the deficiency of glucocerebrosidase causes glucocerebroside to accumulate in macrophages.
And these lipid-laden macrophages engorge the spleen and bone marrow. Microscopically, their cytoplasm takes on a very distinct fibrillary look.
Universally described as crumpled tissue paper.
Yes, that exact phrase.
And in alkaptonuria, a defect in the homogentisate oxidase enzyme interrupts the degradation of tyrosine.
So homogentisic acid accumulates systemically. It binds to collagen and cartilage and connective tissue. When exposed to oxygen, it polymerizes into a dark pigment,
causing a blue-black discoloration of the ears and sclera.
and severe osteoarthritis, and urine that literally turns black upon standing.
It is a stark reminder of the fragile biochemistry that keeps us alive. Yet, despite our profound understanding of these pathways, some conditions remain completely elusive. Sudden infant death syndrome, or SIDS, is strictly a diagnosis of exclusion.
Right. Even after a thorough autopsy, death scene investigation, and clinical review, no cellular or macroscopic cause of death can be identified.
It is one of the most agonizing diagnostic categories in pathology, highlighting the limits of what we can currently see and measure. But we have truly journeyed from the macroscopic clinical signs right down to the molecular pathways that dictate health and disease. Pathology really is the ultimate foundational science of medicine.
It absolutely is. But I want to leave you with a provocative thought based on this evolution of testing. We've spent this time discussing the visual recognition of owl eye inclusions for CMV, or crumpled tissue paper macrophages in Gaucher disease.
Right, the classic microscopic findings.
But as molecular testing like PCR and FIESH becomes infinitely faster, cheaper, and more sensitive, capable of detecting viral loads and gene amplifications long before any physical cellular changes manifest, will the traditional practice of a pathologist looking at dyed cells through a glass microscope eventually become obsolete?
Wow.
Are we transitioning from visual morphologic diagnosis to purely molecular data analysis?
That is a massive paradigm shift to ponder. To reinforce what you've learned today on our medical deep dive, here is a quick review question directly from the material. Think back to our discussion on the immune system and inflammation. What is the fundamental difference between the classic and alternate complement pathways?
Good question.
The answer is that the classic pathway requires C1 activation by an antibody complexed with an antigen. The alternate pathway, on the other hand, does not require an antibody at all, and instead triggers directly via microbial surface antigens. Keep that in mind for your next set of boards. Thank you for joining us on this tour of the microscopic crime scene. Keep questioning what you see and keep learning.